If you're a nursing student, I don't need to tell you how stressful the NCLEX can feel. It's like this giant mountain you have to climb. But what if I told you there's a code to it, a secret playbook that explains how the whole exam is structured? Well, there is, and today we're going to crack that code wide open. We're talking about the clinical judgment model. This is your key to success.
See, the new NCLEX is different. It's not just about memorizing facts anymore. It's designed to figure out how you think when the pressure is on, and a patient's well-being is in your hands. So the big question we're answering today is, how exactly does this test get inside your head and measure that critical skill? Here's our game plan. We're going to follow this roadmap step by step. We'll kick things off with a big picture look at the model itself. Then we'll dig into each of the 6 crucial steps a nurse takes in their head, from spotting the very first clue to connecting the dots, and finally, deciding if the case is truly closed.
Okay, let's dive in with the big picture. I want you to think of this model not as some dusty, abstract theory from a textbook. No, think of it as your practical, hands-on playbook for every single clinical situation you'll ever face, both on the test and, more importantly, in your career.
So, what is this thing officially? It's called the Clinical Judgment Measurement Model, or CJMM for short. The people who create the NCLEX, the NCSBN, they designed this 6-step framework for one simple reason: to test your ability to make safe and effective decisions. It's literally the blueprint for the entire exam.
And here they are, the 6 steps. You've got recognize cues, analyze cues, prioritize hypotheses, generate solutions, take action, and finally, evaluate outcomes. Now, the key thing here, the most important thing, is to see how they're all connected. They build on each other. You can't just jump to taking action if you haven't properly analyzed the clues first. It's a logical chain, and following it is what leads to safe patient care.
So, let's get into it. Step 1. Recognizing cues. This is where you put on your clinical detective hat. Your first job is to walk into the patient's room, survey the scene, and start gathering every single clue you can find.
Now, this is exactly the kind of phrasing you're going to see on the NCLEX. Notice they're not just asking for things that are abnormal. They're asking what needs immediate follow-up. They want to know if you can pick out the truly critical clue from all the background noise.
And this is where a lot of people get tripped up. You have to avoid some common traps. For instance, don't just choose something that's abnormal if it's actually expected for that patient's condition. Instead, you're hunting for the high-yield cues. Are the vitals trending up or down? Are there any new or worsening symptoms? Is there a critical piece of information, like an allergy, buried in the patient's chart? That's the good stuff.
Here's a perfect example: tachycardia, a heart rate over 100 beats per minute. Now, a single reading might not seem like a huge deal, but recognizing that this is a classic early sign of potential trouble, that's a high-yield cue that could literally save a life. This is one of those numbers you just have to have locked in your brain.
Okay, so you've gathered your clues. Now for step 2, analyzing cues. This is where the real detective work kicks in. You're not just making a list of facts anymore. You're starting to connect the dots and figure out what all this evidence is actually telling you.
And again, look at the language the NCLEX uses. They'll give you a bunch of findings and ask, does this fit with what we think is going on, or does it contradict it? What they're really testing is your ability to see the pattern. Is the big picture showing that the patient is getting better, getting worse, or is something totally new happening?
The biggest trap you can fall into here is something called anchoring bias. That's when you latch on to the very first clue you see and refuse to let it go. Don't do that. Instead, look for patterns. Is the patient's oxygen level dropping while their breathing rate is climbing? Has their mental status suddenly changed? Those trends are almost always more important than a single number.
This leads us right into step 3, prioritizing hypotheses. Based on your analysis, you might have a few different ideas, a few hypotheses about what's going on. Now, your job is to identify the prime suspect, the single most urgent, most dangerous problem that you need to deal with right now.
And friends, this is the million-dollar question on the exam. It all comes down to risk. What is the most immediate, life-threatening thing that could happen to this patient? Your ability to answer this question correctly is really the core of clinical judgment.
So how do you decide? You use established frameworks. And the first one, always, always, always is the ABCs: airway, breathing, and circulation. That's your foundation. From there, you think about major safety threats like sepsis or falls, and you consider how quickly the patient could get worse.
Okay, now it's time to do something about it. We're actually combining steps 4 and 5 here, generating solutions and taking action, because they are two sides of the same coin.
This is where you come up with a plan and then you put that plan into motion. It's time to make your move.
Now, it is really important to understand the difference. Generating solutions is the thinking part. It's proposing what you're going to do, always trying to pick the least invasive option first. Taking action is the doing part. It's actually implementing that plan, making sure you do it safely, in the right order, and after verifying everything from the patient's ID to their consent.
And when you take action, these 4 areas are totally non-negotiable. Think of it like a pilot's pre-flight checklist. You're always going to run through your patient safety checks, use proper hand hygiene, and of course, you will always verify the 5 rights of medication administration. These details are what keep patients safe.
All right, we've made it to the final step, evaluating outcomes. Your job isn't over just because you gave a medication or performed a procedure. The best nurses are constantly reassessing. The detective has to go back and see if their solution actually fixed the problem. It's time to close the case.
And this is exactly how the NCLEX will test you on this. They'll give you some follow-up data and ask you to judge whether your action actually worked. Was the intervention effective? Did the patient's condition improve, get worse, or just stay the same?
So what you're doing is looking for evidence. On one side, you're looking for signs of improvement, vital signs getting better, symptoms going away. But, and this is just as important, you have to be on the lookout for adverse outcomes. For example, did the medication you gave help their breathing but tank their blood pressure? That's a sophisticated thinking required for evaluation.
So as we wrap this up, you can see how all 6 of these steps really boil down to a few core principles. Always start with the ABCs. Learn to prioritize acute, new problems over chronic, old ones. Always choose the least invasive path first if you can. And remember that trends almost always tell you more than one single snapshot in time. This is the logic that holds the whole model together.
So, we've broken down the code. You now have the playbook not just for passing the NCLEX, but for your entire career. The final question isn't about the test anymore. It's about you. How are you going to use this framework, this way of thinking, to become a safer, more effective, and more confident nurse?